Radiculopathy or not? So I ask the question, isn't all radiating pain from the neck to the arm or the low back to the leg radicular? Well, clearly not if we understand that radiating and radicular do not always mean the same thing. Radicular pain is a very specific definition. It indicates pain that originates from dorsal rootlets, roots, or the dorsal root ganglion. This can be from compression or from ischemia, inflammation, and other mechanisms. Radiating pain may also be referred pain, arising from a sclerotogenous source or trigger points. Let's use some recent publications as a stimulus to revisit the concept of radicular pain. First, in 2011, an entire issue of Physical Medicine and Rehabilitation Clinics of North America was devoted to the topic of radiculopathy, including evaluation and management. Specifically, we will focus on two of these: physical examination in radiculopathy and natural history of radiculopathy. When we discuss lumbar radiculopathy, we will focus on two articles: diagnostic accuracy of the clinical examination in identifying the level of herniation in patients with sciatica, published in 2011 in Spine, and a Cochrane review published in 2010 entitled Physical Examination for Lumbar Radiculopathy Due to Disc Herniation in Patients with Low Back Pain. Links to the abstracts can be found on the home page of this video. Other references will be utilized throughout this presentation. The goal of this presentation is to update the viewer on radiculopathy and associated nerve root indicators by attempting to dispel the three M's: misunderstandings, misconceptions, and myths. We will do this by focusing on a top 10 list approach. Let's start with number 1. The most common cause of cervical radiculopathy is disc herniation. Actually, 80 to 85% of cervical radiculopathy is due to foraminal encroachment. Only about 20% is due to disc herniation. Let's examine why. Unlike the lumbar region, the posterior longitudinal ligament does not narrow at the disc level. This broader attachment means more protection and also means that when rupture does occur, the PLL often will be the structure compressed and the source of pain will then be sclerotogenous, yet may radiate into a similar area as the corresponding nerve root. Note that with initial pressure on the PLL, there is no actual impact directly on a nerve root or spinal nerve, but a distribution of pain down the arm may occur that fools the examiner into thinking it is radicular. Next, the upper nerve roots are inferior to the intervertebral foramina. The lower nerve roots tend to be at the level of the disc, such as C6 and C7, but C8 is usually at the upper level of the IVF, above the IVD, usually protected from disc pressure. Next, consider that radiculopathy is more common in the older patient, its peak at age 60. However, the nucleus pulposus is virtually non-existent, starting at around the age of 45. Yet beginning around this time, osteophytes become more common. With osteophytes as a source of compression, it's all about location. Let's review. The dorsal root is in contact with the superior articular process. Also, the dorsal root ganglion is situated in a small notch on the anterior surface of the superior articular process. The ventral root contacts the uncinate processes. Also, we can see other potential compression sites related to posterior location. Osteophytes may serve an inadvertent role in prevention of nerve root pressure by forming a protective wall. Osteophytes, in particular of the uncinate processes, may block any compression from disc herniation on nerve roots. Now, let's move on to number 2. Patients trace a dermatome when they have nerve root involvement. Well, most experienced clinicians have come to realize that most patients don't cooperate with a textbook drawing of a dermatome when demonstrating their radiating pain. A study by Murphy et al. Examined how often patients with radicular pain described a patient that was dermatomal. With the exception of C4, patients indicated a non-dermatomal pattern in close to 70% of cases of cervical radicular pain. And for C4, there were only a few patients represented, which may make any conclusions about that level questionable. And except for S1, non-dermatomal patterns were described by patients with lumbar radiculopathy around 64% of the time. So why is that? For convenience, we describe neural segments of the spine as separate spinal segments and imply then that each corresponding spinal nerve contains only fibers from that segment. Research has demonstrated that this is simply not true. For example, some sensory nerve fibers from the C5 spinal segment may not be distributed to the C5 spinal nerve, and nerve fibers transmitting different sensory modalities from the same area of skin may be derived from different contiguous spinal segments. Also, overlap of fibers causes overlap of innervation and therefore dermatomes, so that loss of fibers from one spinal nerve may be compensated by this overlap so that no sensory loss at all is found. Let's move on to misconception number 3. Patients claim weakness when they have nerve root involvement. In patients with electrodiagnostic evidence of radiculopathy, 64 to 75% will have weakness on exam. However, only 15 to 34% will complain of weakness. In addition, 31% will have no weakness on examination, and 33 to 45% will have no sensory abnormalities. An interesting study in 2007 indicated that although forearm flexion and wrist extension are used for C6 and elbow extension for C7, pronation is an option. Using patients with documented nerve root involvement, 72% of those with C6 involvement had pronation weakness. Wrist extension was weak in 36%. For C7, 23% had pronation weakness with elbow extension weakness. However, pronation was the only weakness in 10% of C7 nerve root cases. So from a protocol perspective, resisted pronation should be considered as a valuable additional motor function test. Misconception number 4 is that patients who have nerve root involvement and describe a pattern of radiation will have numbness throughout the path of the pain described, or that if there is sensory impairment, it will be distal only. Let's look at several elements to remind the clinician that there are several clues here. First, look at the dark, thick lines indicating the radiation of pain for each nerve root level. Now notice that there are small circles indicating where some patients indicate where the pain focuses for them. Also notice that there are heavily dotted patches indicating where patients often describe a dull ache. Next, let's highlight in green where the actual areas of numbness are commonly found. We can see that for L5 and S1 there is distal involvement, but for all levels of L4, L5, and S1 there are some proximal areas that could be missed if only the distal neural examination is used. Also notice that numbness is patchy. It does not extend throughout the entire path of pain radiation. Here is the cervical dermatome map. For cervical radiculopathies, most of the numbness is found distally. However, how far distal needs to be considered when, for example, looking at C5, where the pain radiation may be only as far as the elbow, and the numbness is at that distal end. Also, note for C8 that the dotted line indicates an area of sharp pain on the inside of the arm not directly visible on this drawing. Diffuse patchy areas illustrated here again indicate areas where patients may describe a dull ache. On to misunderstanding number 5. There is only one muscle that is found weak with each nerve root. First, let's remind ourselves that the single muscle approach is for clinical expediency. It is simply a way of targeting in on a nerve root, but even basic knowledge of neuroanatomy would suggest that multiple muscles would be affected by nerve root involvement. In one study where patients with known nerve root involvement were tested for muscle weakness, the percentage of patients with an L5 or S1 nerve root involvement were listed for a number of movement pattern weaknesses. These included dorsiflexion and plantar flexion of the ankle or toes, foot eversion, knee flexion, and hip abduction. Looking at S1, we expect a high percentage of weakness for plantar flexion, which we see here at 82%, meaning 82% with an S1 involvement had that weakness. But look at the 75% column and notice this is knee flexion. Next in line percentage-wise is hip abduction. Although these tested high in the majority of patients, they're not commonly tested for an S1 involvement. Here are the findings for L5 involvement. Again, no initial surprise of weakness in first toe dorsiflexion, called extension here, but equally affected are dorsiflexion of all the toes and of the ankle. 63% of patients had weakness of eversion of the foot. Again, most clinicians would simply test dorsiflexion of the first toe. Now, heel walking might catch weakness of ankle dorsiflexors. Next, we move to number 6. Trauma is usually reported as the cause of cervical radiculopathy. There is actually only one U.S. study addressing the etiology of radiculopathies in the cervical spine related to trauma. It indicates that trauma is reported in only 15% of cases. Number 7, lumbar disc herniations compress the nerve root that is exiting at that level. Remember that the spinal cord ends at around L2 and the nerve roots dive vertically from that point. Their exit crosses the disc of the upper level, meaning that at the L4 and L5 disc, the L4 nerve root exits and crosses the disc. So here on the more lateral view is where this occurs. Now looking at the more three-dimensional view on the right, notice why the nerve root that will exit at the disc level below is affected. The reason is because the lateral herniation is not usually far enough laterally to catch the same nerve root, but because of the vertical location of the lower nerve roots, in this case L5, it's compressed prior to its exit at the unaffected disc below the L5 S1 disc. We're up to misconception number 8, that the straight leg raise is positive for nerve root involvement only from 30 to 70 degrees. The prior rule, taught still by most professors, was based entirely on cadaveric studies. The assumption was that the SLR was positive because of dural tension. Dural tension did not develop in cadavers until 30 degrees and above to about 60 degrees. Because the cadavers could not give feedback on pain, there was no real confirmation of this observation. Later, a study by Johnson et al. In spine compared the positive SLR findings on patients with known radiculopathies and recorded the range of motion in which it was positive. The SLR was positive in 42% of patients between 0 and 30 degrees, and was positive in only 26% of patients between 30 and 60 degrees. Now, given the SLR is one of the key tests used for lumbar radiculopathies, using the common direction of a positive below 30 degrees as not an indicator of radiculopathy would be incorrect in almost half of cases. Number 9, there is always radiation of pain into the extremities with radiculopathy. Well, that depends. First, on the specific fibers affected, but more importantly, the location involvement, meaning if the process is more central, as with central disc bulging or with some forms of stenosis. The pressure is first on the posterior longitudinal ligament, which may cause referred pain, but not radicular pain. Let's look at this graphically. Note here that the nerve root is not affected. But also notice that the PLL, especially in the cervical region, where it does not narrow over the discs, can also protect the nerve. The symptoms are generally related to eventual spinal cord pressure, not nerve root compression. Given this is the anterior spinal cord, the influence is more on strength and reflexes. Well, finally, number 10. All those tests I learned and used in practice are equal in ruling in or ruling out radiculopathy. The reality is, until recently, we simply did not know the relative value of these tests. Now research has given us some clues of how and when to use these tests. Let's start with lumbar radiculopathy. We can see here a number of orthopedic and neurologic tests with their evidence-based performance listed as likelihood ratios, or LRs. As a reminder, a very high likelihood ratio tends to rule in a condition when present, and a very low LR, say below 0.1, tends to rule out a disorder when absent. Although listed here as positive and negative likelihood ratios, There really are only high and low ratios. The positive and negative designation is for easier use. How does this relate to sensitivity and specificity? Well, generally a high LR is related to high specificity and a low LR is related to high sensitivity. We can see here that some tests are better at ruling in and others for ruling out a disorder. It's unusual to have a test that does both. So we can see this as a sequence in application. Starting with a highly sensitive test, one with a strong negative LR, we can screen for a disorder. If the test is negative, we can feel fairly assured that the disorder is not present. If positive, we need a specific test to rule in, one with a high positive LR. So for lumbar radiculopathy, we see some of the better tests based on their diagnostic odds ratios, meaning their relative ranking using positive and negative likelihood ratios. We can see that those with the lowest or most negative likelihood ratios are weakness of ankle dorsiflexors and the straight leg raise. Obviously, the weakness of ankle dorsiflexion is more specific to L5, whereas the straight leg raise is a general test. If negative, it's less likely that a radiculopathy is present, but we're still not so sure. Let's add in some more specific tests. So see here how weakness of ankle dorsiflexors, calf wasting, and a cross straight leg raise are decent at ruling in, but not at ruling out. The strongest evidence would be a positive on both the tests with high positive and negative likelihood ratios. If not found, can we combine with the neuro exam to feel more confident, at least about rule in? Given the vast majority of disc herniation is at the L4, L5, and L5, S1 disc, affecting the L5 and S1 nerve roots respectively, let's focus on these. Here are the results of a study in spine that demonstrates that an S1 nerve root involvement is likely if three of the following S1 signs are present: pain projection into the S1 area, a pathologic Achilles reflex, and sensory loss in the S1 area. Now also remember that with age, the absence of S1 reflexes is very common, often bilaterally. One other caution here is that the S1 pain radiation pattern, often called sciatica, is found with any lumbar disc lesion. Now for L5, similar to S1, it is 87% probable that there is an L5 involvement with three L5 signs. The difference is that instead of a pathologic reflex as seen with S1, weakness of the extensor hallucis is used. This is simply because the deep tendon reflex for L5 is so unreliable. So weakness of the extensor hallucis, pain projection into the L5 area, and sensory loss in the L5 area are most valuable. Now let's look at cervical radiculopathy. Similarly, we can see here the rating for both orthopedic and neurologic testing based on likelihood ratios. Looking at the diagnostic odds ratios for the top tests, we can see again the better rule-out tests, the ones that are both sensitive and have a low or negative likelihood ratio. And the opposite, those that are highly specific with high likelihood ratios. Based on this and our understanding that tests with good negative likelihood ratios, especially those lower than 0.1, are good at screening for a disorder, we can use these to screen for cervical radiculopathy. This would include both the upper limb tension test and range of motion less than 60 degrees. If there is no positive on the upper limb tension test and range of motion is greater than 60 degrees, it's unlikely to be a cervical radiculopathy. However, if either or both are positive, using cervical traction and Sperlings, which are very specific, we can rule in radiculopathy if they are positive. Remember that distraction is designated so that a positive test is relief of radiating pain. Put together as a clinical prediction rule, Weiner et al. Determined that if all four of these were present, it virtually ruled in a cervical radiculopathy. With fewer positives, the diagnosis is less clear. The best rule-out exam was the upper limb tension test. To review from the beginning of this presentation, if there was a positive for cervical radiculopathy, it is far more likely that foraminal encroachment is the problem, not disc herniation. So now we can make a general statement about the ability to detect radiculopathy for involvement of either the cervical or lumbar region. You can in many cases, in fact, know when someone has a radiculopathy, but you can't always know that they don't, meaning you can't always rule out a radiculopathy. This is because positive exam findings are not always found with patients who have nerve root involvement. How to proceed? If the findings do not support a radiculopathy, meaning in particular that the sensitive tests were negative, proceed with caution, but you're likely not dealing with a radiculopathy.